It's called tearing the heart. Okay, this is a patient who is 63 years old. She's a female, and she has mitral stenosis, and she has a progressive dyspnea. Now I'll turn to the echo loops, and I'll first of all just walk you through the diagnosis of mitral stenosis, and obviously we'll have to find out if it's severe or not. Actually, very easy to make. It's very easy to make a decision because the diagnosis of mitral stenosis is characterized by doming of the anterior leaflet and by the typical thickening of the leaflet. Even though the image quality is not terrific in this case, I think you will all appreciate that there is doming of the mitral valve. So the diagnosis is quite clear. The only question, where is it, and how strongly is the valve affected by rheumatic disease? Okay, so here is the color flow, which shows you that there's turbulent flow through the mitral valve, and then you can go to the short axis view. You see a bit of thickening of the subvalvular apparatus. These images are not of very good quality, but the apical views are, and this will show you now more about the morphology of the valve. I'll just increase the gain a bit here. Again, we have doming of the mitral valve. We have thickening of the chordal structures. There's a bit of calcification here, and typically in rheumatic heart disease or rheumatic mitral stenosis, we have an enlarged left atrium. Good. This is maybe a better image. Again, we have thickening of the mitral valve, subvalvular apparatus, large left atrium. There is good right ventricle function. The right atrium is not very large, and if you take a look at color, you will appreciate the so-called candle flame phenomenon, which means that there is high turbulent inflow through the mitral valve into the left ventricle, and you have the typical pattern of brighter colors in the center, and then less colorful colors or pixels around the center, and then you have a typical flow convergence zone. I'll just turn this down a bit. Right here, you see, right here is this flow convergence zone, which just means that blood is really trying to pass through this orifice, and causes this flow convergence zone, right? Elevated flow here in this region. Good. So the diagnosis is clear. The next thing we have to take a look at is what are the gradients. And remember, the patient is symptomatic, and this would make us believe that stenosis should be severe, especially if we think that mitral stenosis is really her problem. And to calculate the gradients, obviously you just trace the Doppler spectrum across the mitral valve, and then you get a gradient, in this case, of 23 or 24 millimeters mercury, a mean gradient, and a maximum velocity of 3.3 almost. And then you can also perform a so-called measurement of pressure half time. This is this here. You kind of just put the line here on the slope of the E wave, and thereby calculate the pressure half time. I'm sure most of you know this already. You can look that up also in the lectures. In any case, what we calculate here is an orifice area of 0.8 centimeters and a mean gradient, as I mentioned already, of 24. So this is very severe mitral stenosis, and it clearly explains the symptoms of the patient. Remember, this is a study at rest. If you would increase the workload, if you would put her on a bicycle, these gradients would increase over proportionally, maybe to the factor 2 or 3 or 4 even. So the patient, no question, will have very high gradients, which are even higher than those at rest when she exercises, and those simply explain her exercise-induced dyspnea. So there is severe mitral stenosis. The next question we'll have to ask ourselves is, what do we do now? Now, from a clinical point of view, we have to help this patient, obviously, and since she has dyspnea, she's symptomatic, and we now documented severe mitral stenosis. This is a clear-cut indication to either perform surgery or valvuloplasty, right? So the thing we would now discuss is which of the two is the better option. Let me just go back to the presentation here. Okay. So if you look at the indication for intervention or surgery, it's obviously severe mitral stenosis, and if the patient is symptomatic. So those are the indications to do something. And the two options you have is to do surgery or valvuloplasty. Okay, and the option, which of the two you do, is kind of a bit of a thing that you have to decide individually. If you're in a setting where you don't have access to vascular surgery, obviously you'll do valvuloplasty. This is the case maybe in many remote areas, maybe in India or whatever, where the procedure of valvuloplasty is much more frequent than surgery. And it also depends on the morphology of the valve, because you have to know if the valve is suitable for the procedure of valvuloplasty. Not all valves can really be cracked with a balloon in valvuloplasty. So the next thing we will have to do is we'll have to take a look at the mitral valve in echo and decide if this patient is really suitable for the procedure. We'll just do this right now. And there are certain criteria which you have to look into. And in the workbook, as well as in the lectures, I keep on talking about the so-called Wilkins score or block score. And that takes into account several factors. One factor is thickening of the mitral valve. Now, this is certainly a very thick mitral valve. I can show you a few other images. You see how thick the valve here is. There is the whole anterior leaflet measures several millimeters. So there's a grading scale from 1 to 4. In this case, I would give the patient probably at least 3 for this. And the next thing you take a look at is calcification, which is not so bad. I would say it's somewhere moderate, so maybe a 2 for this. So that would add up to 5. Then you look at the subvalvular apparatus. To look at the subvalvular apparatus, it's best to use long axis view, apical long axis view. Let me see if I can find a good one here. This one is, I think, okay. Well, this is better. Not so good to see here. And in any case, there is thickening of the chordal structures here as well. I'll just increase the gain here. Hope you can see this. And this would, in my point of view, also mean at least 2 or 3. So we have 3 plus 2 is 5, plus another 2 is 7. And the last thing we have to look at is the mobility of the valve. And the mobility is rather okay. Remember, when we looked at the short axis view, there is still a lot of doming, so the basal and mid portions are moving quite okay, but still it would kind of add up to 2 or 3 maybe, I would say. And so we'll have a score, Wilkins score, in the range of maybe 10 or 11, which is fairly high. So this is not, the ideal candidate for valvuloplasty, but still, it's in the range of something that you might want to do. So what did we do? Well, we talked to the patient, and the patient was not too keen to have surgery performed, and we discussed all the options, and we thought, well, maybe valvuloplasty is the way to go, simply because she's rather young. We might win a few years until she then finally has to get an artificial valve, which has a lower risk of obviously getting endocarditis and so forth and so on. So we said, let's just try it. Let's see what happens. Maybe we can help her. If it does not work, we'll just have to go for cardiovascular surgery. That was the plan. And just a few weeks later, we then actually performed the procedure. And we do this procedure usually with just transthoracic echo as a monitoring device. In this case, we also use TE. Simply for the reason that I explained before, because we thought the valve is maybe not the ideal valve to look at. And then, when these patients are on the table and they don't have such good image quality to start out with, it's probably a good idea to have a probe inside and to do the whole thing under anesthesia and to have the patient just to, be monitored by TE. So this is the image now that we had when we started out. You can clearly see again that the mobility is okay. You can see that there's thickening, marked thickening of the valve. There's calcification here. Again, the mobility of the valve is probably the best thing here. And if we look at all the different factors, another issue to look at is the calcification in the commissural regions, which was also there. I just can't show you this here now. And then we just went on and we performed the typical transeptal puncture. You try to find the right spot to go through there. Then you kind of put the needle through. Here you see the interatrial septum. This is the secundum part. This thin part here is the primum septum. There is the needle here. You see it right here. And then you kind of poke it through and you see the tenting. And if you're lucky, you can see all of a sudden, this tenting pop, and the needle going right through to the interatrial septum. And then you put the introducer through the interatrial septum. Just for those who are not so familiar with T studies, this here is the right atrium, the left atrium, and this is the introducer. And through that, you then bring the balloon. Right here, you can see the end of it. Pretty thick thing. If you measure this, it's got, you know, something like, you know, half a centimeter. So it's a pretty thick thing that you're poking through the interatrial septum. Then you approach the mitral valve. We did another measurement of the gradients, which were, you know, I would say at least comparable to what we got from transthoracic echo. Don't forget that you have completely different hemodynamics if patients are under anesthesia. So it's not unusual to find less gradients when you are in the OR or in the cath room. So, but still the gradients are high enough to document severe mitral stenosis. And then we just went on and looked for the right spot to put the balloon through. And then here is now the procedure itself. Right here, what you see is the balloon. It's filled with contrast, with saline and a bit of contrast. And the balloon can kind of be pumped up. You have this contrast kind of syringe that you empty here into the balloon. The balloon expands right at the region where we have the mitral valve, and the idea is to kind of pop the mitral valve and thereby cause the mitral valve to expand. And this is what we did, and you can see that in the moment we do this, actually the balloon also popped because of the calcification that we have. You see that there is contrast all of a sudden here coming from the balloon. So, but we were able to pop the valve, and then after that what we usually do is we look at the echo and mitral regurgitation. And this is what we found after the procedure. Okay. So what are your thoughts on this? Any comments? Well, it does not look so good, actually. I mean, remember, before we performed valvuloplasty, there was no MR. Now this is massive MR. Look at this. Look how broad this jet is and how it really expands all the way to the back of the left atrium, right? Here. So this is very severe mitral regurgitation. The valve itself seems to move okay. It's still stenotic, obviously. We never get complete relief of the complete stenosis, but in a certain sense, we should at least see a bit more opening, and it's kind of difficult to see that there was more opening. I just see that from your comments, many of you also noticed that what you have here is just simply very severe mitral regurgitation. So while on the table, I just wanted to take a second look at regurgitation with transesophageal echo, and this is with transthoracic echo, sorry. And this is the jet we have here. Remember, she was not easy to image, but no question that regurgitation is also severe if we look at it from the outside. What about the gradients? This is the gradients now. If you look at the mean gradient, what you see is actually more than we had before. How can we explain this? This is the pressure half-time, which looks better. Now we have a pressure half-time of 143, so we did do something on the valve. Stenosis is a bit less if we just simply look at pressure half-time, but the gradients are more. I guess most of you know the answer, I just see that Philip gives the right answer here. The thing is that now we have more volume passing through the mitral valve, and this causes higher gradients simply because of mitral regurgitation. Remember, the blood goes back and forth between the left atrium and the left ventricle. Look at this massive MR we have now. So we are kind of in a situation where we are not so happy, and we discussed what we should do, and we were almost about to bring the patient to surgery right away, and then we said, well, you know, let's just see how she does. Maybe we can stabilize her, and maybe MR will be okay, and if we do have to operate her, we'll just plan operation and see what goes then. This is how we put her off the table. And next day we followed her, and obviously regurgitation is not gone yet. It's still here. As a matter of fact, now we have a situation which just looks hemodynamically completely different. We have a small ventricle because the patient has mitral stenosis. Remember, patients with mitral stenosis have a small ventricle, which means they cannot accommodate large volumes. But the patient would have to accommodate large volumes because now she has regurgitation. This means that her small ventricle is in no way adapted to the sudden increase in volume overload, and this caused her to decompensate or to have very severe symptoms of heart failure. And she had very high pulmonary pressures, and as you can see here, the right ventricle now is starting to fail. Look, right ventricle is dilated, and right ventricle function is poor. It's just moving up and down, but it's not moving inward. This was not a good sign. Okay, so she was really deteriorating, and I think taking it from there, I can just give you the final conclusion of this case. We just simply had to operate her. There was no other way. Here you can see again the jet in a short axis view. It's just passing right through the mitral valve. Here again is the gradients, which are very high. Remember, we started out with a gradient of 23 or 24 before we did the procedure. And now all of a sudden, let me just see, we have a gradient of, 38. So she is worse off than she was before, and we just didn't have to take her to surgery. And luckily, everything went fine, and she now has, an artificial mitral valve, and everything went okay. But I think the key message here is that we have to select the right patients for this procedure. This patient was not an ideal patient, and we have to understand that the gradients across the mitral valve obviously are influenced not only by the degree of mitral stenosis, but also by the degree of flow across the valve, which is very high if we have severe mitral regurgitation. Okay, this was the case that I called Tear It Apart. I hope it also showed you a bit how to assess patients with mitral stenosis and some of the difficulties we encounter in this situation.